Good morning, Dr. Maribeth and my classmates. My name is Jiwon. Today I'm gonna present a case on a patient with type 2 diabetes who developed cardiovascular complications. I'm gonna go through with the patient's case, introduction, pathophysiology, diagnosis, management and treatment, as well as the complications and prognosis. As we go through with the patient's informations, we can somehow see how this patient brought to the emergency room. So he's a 55-year-old Chamorro male living in a Saipan with a history of type 2 diabetes since 2015, hypertension, chronic kidney disease stage 3, hyperlipidemia, morbidly obese, and non-compliant with medication management or the treatments. So he came to the emergency room with a complaint of SOB, fatigue, exertional dyspnea, chest tightness, and ankle swelling for 1 week. Patient is a sedentary. He's having a sedentary lifestyle with a BMI of 32, and his diet is also improper, like consuming a high processed food and like mostly like canned foods daily. He also smokes like 10 sticks of cigarettes per day and chews some betel nuts sometimes. This is very typical in Saipan cases. Risk factors with a poor glycemic control, smoking, chewing betel nut, non-compliant with medication treatment, and a family history of cardiac disease. Initial vital signs: BP of 165/90, heart rate of 96, respiratory rate of 22, and then O2 of 90% on room air. Patient said that for a few days he felt tired and weak, and then last night he had a little chest tightness and some catching of breath after he walked to the toilet, which he shows that he has an activity intolerance or exertion SOB. He said he couldn't take his home medications, which was prescribed 2 months ago from his primary doctor because of a financial issue and a problem with the insurance. So for objective findings, we found he has a bilateral pitting edema grade 2 on his ankle and lung crackles upon auscultation also in bilateral lower lobe. Lab findings shows elevated sugar, troponin, and also a bumped up of a BNP of 4,230. Considering of CKD and poor glycemic control, his kidney profile is also elevated too. In images, he took the chest X-ray. We found the fluid in the bilateral lower lobe, and which is one of the most important is the echocardiogram, and it shows that he has a ejection fraction of 40%, which confirms that he has a reduced cardiac contractility. Urinalysis done also to check if the patient has diabetic nephropathy. So far, the albumin creatinine ratio is still within the normal with a trace of protein and a glucose. So given all these informations and studies, I brought down 3 differential diagnoses which are applicable for my patients: the heart failure, ischemic heart disease, and diabetic nephropathy. For diabetic nephropathy, the typical sign is the albumin showing on the albuminuria in the urinalysis and some proteins as well. But so far as urinalysis, his albumin is still within the normal, and due to chronic hyperglycemia, there is a showing of some glucose, but still the main problem right now is considered as a heart cardiac complications. So given with the ejection fraction of 40% and then symptoms of left-sided heart failure and increased level of BNP, I believe that right now his probable diagnosis is the heart failure, particularly diabetes with the cardio-related complications, the left-sided heart failure with the reduced ejection fraction. The problem with the chronic diabetes is that it changes the metabolic system in the body, which actually affect the systematic systems in the body. So considering the patient is having a 10 years of diabetes, smoking, hypertension, and renal disease, uh, we can expect that there is a persistent elevated glucose, which affects actually cardiac cells, causing a decreased efficacy of an intracellular calcium efflux and decreased contractility. Also, impaired insulin signaling increases lipolysis, causing a lipotoxicity of a cardiac cells, which stimulates the fatty acids developing uh, in the myocardial cells, as well as the increase of a resistance to insulin and hyperglycemia. It also stimulates the transforming growth factor and some fibroblast proliferation, causing interstitial fibrosis, leading to a thickening of the ventricular wall. So all these things, the forming of advanced glycation and end products, which triggers the oxidative stress and inflammatory signaling. These all things can actually changes of a left ventricular structure. We call it a structural remodeling, make it hypertrophic in the thickening of the myocardium cells. So imagine there's already a thickening of a myocardial cells, but still uncontrolled hyperglycemia. It reduces nitric oxide availability, increase the vasoconstriction, and promoting more inflammations response, which also causing a buildup of atherosclerosis. Also, diabetes activates the renin-angiotensin aldosterone system and sympathetic nerve system. This increases the afterload and the preload of the heart, which worsens the heart failure. And increased reactive oxygen species also damages mitochondrial and DNA in the cardiac cells, which means it decreases the contractility of the heart cells as well. So all these things happen together, especially also the patient has kidney disease. So impaired kidney function contributes also in a heart failure, like inability to excrete the waste and imbalanced electrolytes, causing a fluid retention, and then giving more burden to a heart, leading to more pulmonary congestions and peripheral edema, and so on. So diagnosis can be confirmed with some several tests, such as hemoglobin A1C, BNP, and lipid profile. Usually in a heart failure patients, BNP is the cardiac marker to check first and see if it's elevated or not. And we can also have an ECG to check any dysrhythmia or arrhythmia present. And another important study is the echocardiogram, which usually shows EF below 40% with the left-sided heart failure reduced ejection fraction. And to check urinalysis as the patient has a CKD, and we also have any to see if there's any chance of patient having a diabetic related nephropathy as well. Some cases in mainland but not practicing in Saipan, cardiac MRI and some other genetic screening may be also performed based on the patient's inherited risk factors or structural abnormalities. For management and treatment plan for the heart failure, we can divide it into acute and a chronic phase. So considering the presenting symptoms with SOB and some chest tightness, we can address first with the oxygen, nitrates, and morphine to improve myocardial oxygenation and relieve some coronary spasm or symptoms. As a typical sign of a heart failure is fluid retention, causing a more workload on the heart. Diuretics will be given to reduce the preload and excrete some excess fluid in the body, while ACE inhibitors, ARBs, and aldosterone blockers also can be given to reduce the both preload and afterload. In severe cases, they're also considering of surgery options like coronary bypass, PCI, intra-aortic balloon pump, or we call it LVAD. For chronic management, the focus is on reducing both preload and afterload, improving cardiac function, and also controlling risk factors at this time. So, as what mentioned earlier, continue with the diuretics, ACE inhibitors or ARBs, combined with the beta blockers and aldosterone antagonists to reduce the work preload and afterload. Recent guideline also said that the valsartan and SGL2 inhibitors such as dapagliflozin and empagliflozin can also have benefits with the mortality in the heart failure patients. Non-pharmacological strategies include maintaining a proper diet like low sodium, low processed food, and low red meats, increased fibers, and having more vegetables. Also, with the regular physical activity as tolerated, do not go beyond the excessive um, exercise, of course. Also, considering this patient's BMI, weight loss must be maintained, and stop smoking, and also teaching of importance of diabetic management as well. Complications of a heart failure pretty much with the reduced ejection fractions include arrhythmia like AFib, and then progressive ventricular remodeling, eventually causing a cardiogenic shock, thromboembolic events as well. With the advanced heart failure, it can cause pulmonary hypertension, right-sided heart failure as well. In systematic effect, it will also cause some renal dysfunction, liver dysfunction, malnutrition, and electrolyte imbalance. The prognosis of a left-sided heart failure with a reduced ejection fraction is usually poor, especially when it's associated with diabetes, because there are many changes with the mechanisms in the body, causing an abnormal structural function and then losing of ability of the normal cells. So there are high rates of readmissions in the hospital to treat the acute symptoms, and then also even though there are some appropriate treatments ongoing, there are many cases like progressive decline, and then symptoms such as like fatigue, exertion SOV, and exercise intolerance can actually impact their daily life activities and causing a low quality of life. Thank you.